It's 1 minute after noon. I'll go ahead and get started with the welcome and housekeeping. And then we'll go ahead and get started. I want to remind everyone that the seminar is being recorded. So thank you for being willing to be recorded. This is today's Dissemination Research and Implementation Science Seminar. My name's Heidi Brown, and I'm the moderator of today's DRISS session. I am an associate professor in the Department of OBGYN and also core faculty on the Dissemination and Implementation Launchpad. And we launched this seminar in the fall, and this is meant to be an interactive monthly lunchtime virtual seminar to learn about the growing science of dissemination and implementation. We're so glad that you're here to join us. You can turn your camera on, you can turn your camera off. We encourage you to eat. We hope that you'll continue to join us for future sessions. And at the end, I'll put some links in the chat for how you can register. I'm really excited for today's speaker, Dr. Barb King. She is going to give us a talk about using REP and REAIM to implement a complex mobility intervention in a hospital setting. Importantly, she started this work before COVID and has had many lessons learned navigating through and are we beyond the pandemic? Professor King is a professor at UW-Madison in the School of Nursing. Her research focuses on improving outcomes of hospitalized older adults. She uses mixed methods in her study designs and has investigated older adult experiences with hospitalization, ambulation recovery post-discharge in older adults, and multi-component systems-based interventions to improve ambulation during hospital stays. And I think that's what we're going to hear more about today. So without any further ado, I'm going to turn it over to Barb, who will talk for anywhere between 30 and 40 minutes, and then we'll open it up for some robust discussion. So thank you so much for being here, and I can't wait to hear your talk.
Very good. So I am just hoping that this works for sharing. Can you see my slides? Yes?
Yes, we can.
Very good. So let me just get this into this mode. How about now? Still good?
Beautiful.
Okay, very nice. All right. So this is not the one you need because this is my training intervention. Okay, wait a minute. Let me get rid of stuff here. Things are opening in the background. All right. How about, hey, Lindsay.
Lindsay, we're so glad you're here. I've been bragging about how the seminar is drawing international participation.
All right, how about now?
This looks like the right presentation.
This is the right presentation. We are working on this. Okay. So I'm going to present, I'm glad Lindsay was able to join us from down under. I'm going to present our study that used REP and REAIM to implement our complex mobility intervention, which is titled Mobilizing Older Adults via a Systems-Based Intervention. I just first want to acknowledge this project was made possible through the School of Nursing and ICTR funding and WPP. It's really important to acknowledge our stakeholders and partners in this project. This could not have been completed without them, without our COI, Mary Hook at our site, without our project assistants. And of course, this was never going to come to fruition unless Lindsay and I got our heads together to figure out how to address this issue, how to attack system-based issues that prevent patients from getting up to walk. And I'd like to say I have no conflicts of interest to disclose. So we have been talking about the substantial negative consequences about immobility or low mobility since the 1940s. So it's like a broken record. We just keep talking about this, about what happens to patients when they enter our healthcare systems and we don't let them move. Same conversation, just different titles. So back in the 1990s to very early 2000s, we talked about this as functional decline in hospitalized older adults, as that was the population that seemed to be getting most impacted. And so those key sets of interventions and studies really looked at activities of daily living, the 6 basic ADLs, and patients coming in independent in their ADLs and then being discharged, now newly dependent, in one or more of those ADL activities. And then we saw a shift. So sometime around early 2000s, we shifted from talking about ADLs to talking about loss of independent ambulation. And this is loss of independent ambulation across a small room that these older adults were experiencing. And then we shifted again. Now we're hearing terminology such as trauma of hospitalization. So this loss in function is now one of the 4 traumas that occur and now being identified as a post-hospital syndrome. So I think the theme here is that we have a direct patient injury that's happening in our hospitals. We don't acknowledge that we are actually having a patient injury occur. So what is the critical nature of patient ambulation? So you're getting all my precondition stuff right here in REAIM and REP. So we know there is so much data available that has directly shown that lack of walking or ambulation during a hospital stay is directly linked to bad patient outcomes and negative healthcare utilization issues. So loss of muscle strength and mass, typically in older adults, if they're not really moving very much, that loss of muscle strength and mass is about 5% per day. So older adults in general have a lower muscle mass anyway because of the aging process. We get them into hospitals, we don't let them move. We see this rapid acceleration of muscle mass strength and loss, particularly in the lower extremities, the hips, thighs, ankles, so on and so forth. We know Jane Mahoney's work did a nice job showing that the first 2 weeks post-discharge is the highest rate when falls are going to occur in an older adult population that's been hospitalized. We have tons of documentation that's shown that not getting patients walking increases falls both during and after hospital stay. In particular, B. Kalish in Michigan looked at this in terms of missed nursing care and directly linked. When nurses miss ambulation, falls increase. So we know that it's going to cause falls. Again, we see loss of activities of daily living. We see huge impacts on the cardiovascular, respiratory, GI-GU, the skin, the sensory. And what we're starting to think about looking at more is what happens to patients in terms of mood and a sense of isolation when they cannot get out of their room during the hospital stay. And certainly COVID has given us a bazillion tons of data on what happens from a depression standpoint when patients are isolated. Cynthia Brown showed us there was a significant increase in mortality rates in older adults when they lost function. People have said to me before, well, they're going to get better. They're going to go home. They're going to do their usual things. They'll get stronger. They actually don't. 50% of older adults who've lost function remain disabled at post-discharge 1 year. So they aren't getting better. They're now permanently disabled. We see increase in length of stay, more than 20% increase in new nursing home placements, and that's because they no longer can function or their caregiver can no longer care for them at home because of poor functional status. And when Tom Gill first looked at what does this cost our organizations and what is the annual expenditure to healthcare utilization, back in 2004, he first identified that this was $26 billion. This data was from probably about 5-6 years ago. It was $57 billion annually. So think about our aging population. They occupy more than 60% of inpatient beds. If we continue down this path of restricting mobility and not thinking about functional performance as a quality metric, these numbers are going to continue to substantially climb. So what is our current state of patient ambulation? If you look at the prevalence of new functional impairment for hospitalized older adults, that's going to vary. So we've seen rates anywhere from 20 to about 60%, depending upon how they are measuring and defining functional status. But we know we have all of the data that shows older adults aren't moving. So Cynthia Brown has done amazing work using accelerometers. She did a lot of her work in the early 2000s and continues. She identified that 83% patients are spending their time in bed. She also showed that the average standing time, you look, the median was standing or walking was 3%. That was it. Steve Fisher from Texas has done a lot of work looking at percentage of older adults that ambulate during their hospital stay. He found that only 4% actually are allowed to get up and to walk during the hospital stay. He also showed that older adults spend less than an hour a day in activity. And when you look at the rate of steps that older adults take compared to their community counterparts, it's about, they take about 15% compared to what happens in the community. So we also get into, well, whose job is it? It should be somebody's job to get patients up to walk. The problem is we're not really sure whose job it is. So when studies been done by looking at with nursing, there's a gray area. Sometimes you think it's PT's job. Sometimes you think it's medicine's job because they don't have the right activity order. But is it their job? You know what? They're not really quite sure if it's their job. Which perplexes me as a nurse. You know, like it's a critical component of nursing practice is to maintain someone's functional independence. Jane did a nice study, observation study, and they kind of hung out in the hallway, and patients that were able to walk, they were watching what percent of them were walking at any given time. And what they identified that only 9% of those at that time were patients walking with nurses. We did a study looking at the frequency of nurse-initiated patient ambulation, and we looked at 5 different mobility events. Were they standing? Did they get to a chair? Did they walk in their room? Did they walk to and from the bath? There were 6. And did they get out in the hallway? We found that 30% of patients never had any mobility events initiated by the nurses. Now, any mobility event initiated by the nurses during those observation times. B. Kalish, great study, surveyed over almost 3,000 nurses, in which she found that 80% of nurses report ambulation as their missed nursing care activity. So we have kind of a crisis problem, trying to figure out how do we get patients walking. So we should be able to fix this problem. You know, people say to me, you should be able to fix it. You know, just get them up to walk. It's not that easy. It's really actually incredibly complex. And the complexity is because there are so many barriers to getting patients walking. System barriers are huge in thinking about how do we get patients walking. So with the onset of CMS's directive that fall should be a never event, and we'll talk about that in a little bit, what we have seen is an unintended consequence of that. We really don't have any strong evidence to show this is an effective program to prevent falls in hospitals. So hospitals are getting that message. And the issue is you wanted to not have injuries with falls. So the interpretation of it is you can't have any falls. So what we found is an unintended consequences of these fall prevention is that the best way to not have a fall is to not let people move, particularly in older adult population. So this is a great quote from nurses. Everyone's so afraid to walk their patients. So it acts as a direct barrier. Hospitals, patients are saying really unwelcoming mobility environments. There's no wayfinding. All of the units look the same. So if I venture out in the hallway and I get into a different unit, can I get myself back? Is a problem. There's no place for me to sit and rest if I just feel tired and I want to sit down and take a break before I walk back is an issue. There isn't really a message that you need to get up and walk during your hospital because it's really important for your health outcomes and your how fast you're going to be able to get home and illness recovery. The message we send to them is you shouldn't walk without a nursing staff. So it becomes a really almost hostile environment for mobility. I had one patient tell me during a focus group, you know, when you get out in the hallway, you feel like you shouldn't be there. Like, I shouldn't be out here. So the perception of the message we send and what patients receive acts as a direct barrier. We send them the messages, you can't move, verbally. We send the messages often of, we need to be with you because the concern about falls, and we don't want falls, but I think there's different ways for us to think about how we manage those. But then there's these auditory messages, and those come in terms of use of mobility sensor devices. So if you put it in your bed or your chair, and the minute the patient moves, an alarm goes off. I will tell you that patients directly respond to that alarm. And they will say things like, it's an invisible tie. Other patients will say, I'm a prisoner in bed. Here's a great quote from patients said, I found it was really intolerable. I had an alarm on my bed. I couldn't even get out of bed. I mean, really, I had an actual alarm. And they were just blown away by this experience of being alarmed and restricted in their independence and decision-making. We really don't use patient function as a quality metric. What we use is no faults. We're not using, did you become injured while you were here because you lost your functional status? So we have an issue with that, and that drives down from policy all the way down in through hospital systems. But now we have a new barrier. We have a staffing crisis, and it's, you know, trying to find RNs and certified nursing assistants. We are in crisis mode right now. So there's a limited availability of resources to actually promote patient ambulation. We know that there are tons of barriers for nurses. We've done a lot of work in this area. Again, limited resources. There's not enough staff to help you. There's not enough CNAs to help you. There's tons of competing demands. If you look at the number of times that nurses are interrupted during even half of a shift, I don't know how to get anything completed. So their pagers are going off, their Volceras are going off, family members talk to you, providers need to talk to you, patient gets worse. So multiple competing demands occurring at the same time, which has to shift their attention. We know that lack of opportunity is a direct barrier for nurse engagement in patient ambulation. Often this can be nurse unit related. So we got a lot of admissions coming in. We have a lot of discharges going in. A patient goes critical, spontaneous, quickly, and now effort should be to that patient, and that disrupts the flow of what's happening on the unit. We know that there's poor communication related to patient ambulation. Anna Krupp did a really great study in ICUs in which she talked to nurses about information they're retrieving on activity or ambulation in the chart. What nurses said to her across units is the information that's in the EHR is almost always wrong when it comes to activity. So it's not looked at as a trusted source for gathering information about what is this patient actually able to do. We know that nurses have concern for injury. I'm going to hurt myself, back injury. I'm going to hurt the patient. They're going to fall. And we have a culture that deprioritizes mobility right now. And we have to think about how do we shift that culture to think about ambulation promotion in terms of healing and disease prevention, in terms of mobility restriction. So patient barriers. We've done a lot of work with patients looking at what do they experience related to ambulation during their hospital stay. Patients will say the big things that affect their willingness or ability to get to walk is they feel weak, they've lost muscle mass and strength, they feel fatigued, or they have pain, and all of those act as barriers. Those gowns, they are a barrier to ambulation, often because patients don't want to look disheveled. They don't want to risk exposing their body with a gown on. And because of that, they were more likely to not enter out into the hallway if they feel like they're not pulled together and they haven't adequately protected their personal space. This came from one of our patients in a stakeholder group who said to me, when you come to the hospital, you leave your dignity at the door. So I think we need to think about what are patients experiencing within our healthcare system, and how does that influence their experience, but also act as a barrier. There are tethers. They have to, if they have an IV pole, if they have a Foley, if they have any drains or tubes, they figure out how do I manage this equipment. We often don't educate them on that. Patients identify ambulation in hospitals as a high task uncertainty. They don't know if they can walk. They don't know when they can walk. So they don't know when is your test scheduled, when is the medical team rounding, are there any other treatments I have to hang out for? So they don't know what their opportunity zone is to actually engage in ambulation. And this is really interesting. They actually engage in reciprocal caring of nurses. So they see the nurses running in and out of the room and they say, wow, you're really, really busy. And I'll tell you what the nurse signifies to these patients is, you're my lifeline. You are the consistent 24-hour presence. You're my lifeline. You're going to make sure that everything happens the right way for me, and you're the communication point across multiple providers. So they don't want to burden the nurse. They don't want to put more workload on those nurses. And this is a great quote. When I've been in the hospital, the last thing I want to do is mess with the nurses. They're going to care for those nurses. They're not going to put any undue demand, what they see as undue demand on the nursing staff. So why is this so challenging? So many layers at the patient level, the unit level, the hospital level. But I think we have to think about what is happening in policy that also is impacting and driving these states. None of the Joint Commission's core measures address mobility or functional status assessment, not one. None of the 274 quality measures in the Quality Payment Program, CMS, Medicare Access and Children's Health Insurance Program, the Reauthorization Act, included inpatient functional assessment and improvement in function during a hospital stay, not one. CMS has identified falls in every event, and Ken Govinsky stood up in a lecture at GSA and directly said that Medicare has now waged a war on mobility in hospital settings. So that leaves these organizations to try to figure out how to do this individually. But more importantly, each unit has to figure out how to do this. And each staff has to figure out how to do this. So again, why aren't we walking patients? It's pretty complicated why this is not happening. So Lindsay and I got our heads together back when we both came on faculty. I had this background on what's happening on mobility during hospital stays. Lindsay is a human factors and systems-based engineer. So we thought, how can we design an intervention that addresses some of these barriers so that we can override barriers to actually improve the work of getting patients walking? So we used a systems engineering initiative model for patient safety that was created by Pascal Carrion. That told us what and how within the medical healthcare system that we needed to address to improve the process of patient ambulation. We also overlapped that with the social cognitive theory, which helped us think about the how were we going to actually change behavior at a nurse level and at a unit level. So this is MOVIN. It has 5 moving components at the same time that the intervention is launched. We knew we needed a psychomotor skills training because nurses lacked efficacy in determining a patient's ability to ambulate and then getting patients to walk. And this overarching fear that the patient falls, there's now blame and shame that happens at their level. We knew that resources and opportunity was a critical issue. So we had to think about how do we add additional staff and mobility equipment to maximize these opportunities. We had to think about what are communication pathways that we could develop into an intervention to improve both visual and verbal communication across disciplines related to patient ambulation. We had to think about the environment in itself. So there weren't any measurable metrics within hospital units so we could accurately measure how far patients were walking, to think about progression. And we really knew we needed to do a lot related to unit culture to try to prioritize patient ambulation as the way that work gets done. So we had tested MOVIN initially with our hospital partner, and we had amazing results from pre-intervention to intervention and post-intervention. And they sustained their frequency and distance that they were walking patients. They just kept climbing. They sustained it for 3 years. And that unit has since closed with reorganization. So that whole group of nurses that were involved in that have now been disbanded to other units. So while we were trying to figure out getting through somebody at HRQ or NIH is going to fund this R01 intervention, we thought, well, why don't we try to launch this with another hospital on another inpatient unit? And could a clinical intervention team launch something like this? So we dove into the D&I land of research, and we applied for an ICTR D&I grant, of which we received funding, to evaluate the implementation of MOVIN on it by an on-site clinical team. We had 3 objectives for this. We needed to adapt MOVIN for use in a community hospital, a community-based hospital. We needed to implement MOVIN within a unit, and then we wanted to evaluate the effectiveness of this on-site clinical team doing this implementation. So come into selecting what is going to be the implementation framework that we would use. And if you've looked at the implementation science, there's over 60 frameworks. So we sifted through thinking what seemed to make sense for what we wanted to do. We chose the replicating effectiveness program framework, preconditions, pre-implementation, implementation were the 3 phases we focused a lot on. And then there's a maintenance and evolution phase, which looking back now, we have 3 months post-data, we could probably say we hit that too. So that told us how could we, what is the process of adapting our intervention in another healthcare setting? But then we wanted to have a really rigorous evaluation framework. So then we chose REAIM to do that. And this has been used extensively for evaluation of system-based interventions. It also provided us with structure so that we could identify where additional modifications needed to be made that would help us further facilitate dissemination of movement. So this study occurred across 2 phases, which we've outlined here. So in preconditions, we knew all the literature. We had demonstrated the effectiveness of movement on a first trial run. So now we thought, well, how could we adapt? So we engaged our stakeholders to help us understand what that adaptation would be like to fit a community setting, and then also to help us develop and further refine our comprehensive movement implementation manual. And then we moved into our pre-implementation phase in Objective 1, and I'll go through these in a little bit more detail. Objective 2, phase 2, we were still working on Objective 2, and then we jumped into evaluation is where we brought in REAIM for our Objective 3. So precondition phase, on-site COI was critical to being able to do this. We needed a person there that had buy-in from the organization, that could help us work within the organization, that could help us move throughout the organization, that could get us in contact with stakeholders. So we identified relevant stakeholders that could inform our understanding of the hospital needs and the resources that were required to actually implement this intervention. So here's our wide sweep of stakeholders. And again, that on-site clinical person helped us connect across departments and get us access to these individuals. So we had a fairly large group that we were doing individual and focus group interviews to really understand how did they interpret these 5 components and where there might be barriers or facilitators to that, and then how did we use that then to think about adaptation. Our pre-implementation phase is where we were really working with our what we called our launch team, which was the nurse manager on a unit, a clinical nurse specialist, 2 of the RNs, and 2 CNAs and physical therapists. And we worked with them. We had a really good rough draft of the manual. And after we heard all of the stakeholder feedback, we thought about where we needed to make adaptations within our 5 components. We pulled together this manual with them that they were giving us constant feedback on. And then we used that manual to help guide, orient them, and help them launch their intervention. So the charge in the pre-implementation was this critical feedback we needed to the manual for clarity and functionality. But then working with that team, because they were going to oversee the planning and implementation of movement on their inpatient unit. Launch. It felt like the rocket going most of the time to figure out, because you're letting go of your baby here and you're saying, okay, let's see what you do with it, and standing back and trying to not react a lot of times to see what could they actually do when they launched this intervention. The launch takes about 14 weeks, and that's been consistent across every time that we've implemented movement, because we have to get through these 5 components, particularly psychomotor skills training, getting these nurses through this training with physical therapy. So when we went into evaluation phase, we thought about what that design could look like. So this is a pragmatic quasi-experimental design. We wanted to determine what was the effectiveness on this on-site clinical team. The unit served as its own control because we gathered their mobility data before we actually did anything to them. And then we thought about where should this be. We didn't want this to be at the same hospital that we had previously tested MOVIN. So we found another hospital located in Wisconsin. They had a 23-bed adult general medical unit. They were also magnet certified like our prior hospital was. We sampled registered nurses and CNAs. We gathered their ambulation data from the medical record. We also included nurse administrators because they're going to make decisions about whether or not they would adopt and spread MOVIN. And our launch team and physical therapists that were actually key components and partners in this implementation and training. We collected data 3 months pre-intervention. So we were able to mine data from their EHR. 14 weeks during the intervention, and then 3 months post-intervention. So part of REAIM is thinking about, well, how are we operationally defining each one of these components of REAIM? So here is, what is the component? What is the component description? And then how do we conceptualize what this would look like when we did this intervention? So we looked at how many nurses would agree to participate in the psychomotor skills training. Did we see a change in nurse-initiated patient ambulation? Could we identify barriers and facilitators to adopters? And we used a qualitative approach for that. We wanted to make sure that we looked at the fidelity rating of this team implementing these 5 components. And then we wanted to continue to say, what do they do when we are not in their space, constantly encouraging them to see, do they actually maintain this intervention? So how do we do reach? We targeted, we wanted 50% of RNs to volunteer for the psychomotor skills training. So our target was 15 nurses that would hit us at 50%. But our launch team said it's really important that we get at least 2 CNAs as part of that training. One who's the ambulation aide, one who's a CNA champion. Well, you go where your stakeholders are telling you to go. We said, absolutely. So we went with 13 RNs and 2 CNAs. So of the RNs, we achieved a 43% interest and volunteer rate in actually doing the psychomotor skills training. So is it effective? So this is looking at distance in feet. So part of MOVIN, and we put distance markers in hallways at every 10 feet. So nursing staff could rapidly calculate how far a patient's walking outside of the room, but we also knew what distance were from the bed to the bathroom and the bed to the doorway. So we were trying to capture all mechanisms of distance that patients were walking. So this is our looking at distance in feet, and you can see that the average was about 7750 in feet. And then we saw, what did we do when we implemented? That jumped to 40,000 on average in feet. And then it jumped again to 68 at post-implementation. So we saw a statistically significant improvement between pre to intervention and pre to post. We did get improvement from implementation to post, but it was not statistically significant. This bottom line here is physical therapy, because when I hear it's physical therapy's job, I love to show, well, here's physical therapy. They can only do so much. They're only there so much. And their job is not to just make sure patients walk. So they kind of move around, they're pretty constant, nothing really shifts. It doesn't really shift. When you engage nursing staff, you see this steep increase in patient ambulation. So it's a nice augmented effect in what physical therapy is able to do. We also looked at percent of nurse ambulation. And again, we saw is this pre-phase, which was about 49%. We hit intervention, it jumped to 84%. We hit post-intervention, it jumped to 92%. So this is drift. So again, we're working with the implementation team, the launch team, about we got this, the unit knows that something's on. All of a sudden we see drift. Little increases, which I don't know how we're going to get around that. But then we see a really jump when we're able to do all of the 5 components. Statistically significant improvements between pre and implementation, pre and post. And again, even though we saw an increase between implementation and post, it wasn't statistically significant. The adopters, we did this by using a qualitative approach. to interview key nursing administrators, because they're going to make the decision whether or not they would implement this throughout the hospital. We also included in that other key nurse leaders, like people in quality and safety. We got their input in part of this also. And also our launch team members. So what they told us in terms of themes is that there's, as far as a facilitator, there's a value for hospital patients and staff that they would adopt this. Cost savings to the organization if we can decrease length of stay, appropriate use of physical therapy services, which was what we heard from our PTs, and an increase in nurse satisfaction and improved outcome. So we've got great quotes here. Even if we can reduce by half a day length of stay, that's significant for nurse administrators to think about. We could do this hospital-wide as far as a facilitator. But nurses were saying patients are happier. They're more social. They leave their room. They're playing cards with each other, which we didn't know until they started talking about all of the things that were happening on their unit. Again, pre-COVID people, they're playing cards together. They're out in the hallway. MOVIN made me feel like I was a better nurse, which is in terms of satisfaction. And then PT saying, well, the first thing they do now is that they went and checked with the nursing, or they checked with the ambulation aide. And they said, how is this patient walking? And because the nurses had improved their skill and their communication, they could say, well, they're doing great. Here's how far they're walking. They, now I'm no longer using the walker. So that helped the therapist thinking about how are they going to prioritize? Who can they prioritize that they really needed to see instead of seeing everybody? Immediate feedback was critical. They did this by seeing visible changes in their patient's function. We gave them regular data graphics and reports on their ambulation frequency and distance. We blasted them with information. That was critical. And we celebrated every goal they had along the way to boost their unit culture. Those were really important to them. So seeing their progress and how far patients have walked was really important. Celebrations help. It shows we are appreciated. Became a really important component. Another facilitator was inclusive implementation, engaging those nurses and stakeholders along our journey became really important. They had multiple opportunities to give feedback on the launch, and they had an opportunity to tailor MOVIN to fit their unit rather than the unit having to fit MOVIN. So I think this is important when they say we get to be the voice for our unit. So instead of doing things at them, they were a part of the process in making this happen. And then every time I came to a meeting, this is really fun, I get more hyped to get going. So a lot of excitement from that launch team to implement this on their unit. But there were barriers. And two barriers that we identified were resource needs, the additional FTE for an ambulation aide, and the cost for nurse psychomotor skills training. The additional FTE for ambulation aide wasn't that it costs us more, it's they're having trouble hiring. So is there a resource that can even hire CNAs to come in to fill these spots? And then it can be costly to have PTs train the nurses in psychomotor skills training. So what do we got to think about working with our physical therapy partners to try to bring down those cost issues? And then we did not have length of stay data. When we spoke to our nurse administrators, is something that we are collecting in part of the randomized control trial we're now doing. So we saw that as a barrier, that we did not have this organizational evidence, and that we knew that length of stay was really pretty important for us to capture in terms of ACT now. If we can show this reduction, it now acts as a facilitator instead of a barrier. So implementation piece of it, this is where we use Jane's fidelity assessment tools. We adapted it for our MOVIN study. We used this rating scale of excellent, satisfactory, unsatisfactory. We did observations with myself and Jillian Bowden, and we did these measures at 1, 5, and 12 weeks. And we were observing how did they do the psychomotor skills training, because I wasn't teaching that. How were they using the whiteboard? How were they adequately using the ambulation aid? Did they get pulled out of staffing? Was there mobility equipment up on the unit? And so what we found is that all of these components were achieved at satisfactory or excellent in the fidelity ratings at each time point. It was important for us to think about maintenance. So we thought about these 3 months post-intervention. Did they sustain it? They did. They sustained it, and they did a little better than what they were doing during implementation. We continued to track distance and percentages weekly and continuing to watch what was happening on the unit. And again, both of these measures were consistent and sustained. So what did we learn? We learned so much doing this intervention, and how it's really helped us thinking about further dissemination of MOVIN. Including multiple stakeholders within the hospital was critical and key to our understanding of local context for shaping MOVIN to fit the organization. We also learned that the flow of information and the speed of which we were delivering information could produce information overload to a launch team. So we had to think about how do we break down and chunk information so that we don't get into that situation of them feeling overwhelmed and feeling like they can't achieve this goal. We were kind of surprised about the amount of coaching that was needed, and that's related to readiness. So we had chief leaders in the organization saying, oh yeah, we are ready for this. We do these improvement interventions all the time. You got at the unit level and they're like, we've never done these kind of mobility quality improvement interventions. We have no idea what we're doing. So there was a very big difference in higher level organization, how they thought about readiness, and what happened at the actual unit level for readiness. So that tells us that readiness really needs to be assessed at multiple levels when we think about doing these kinds of implementations. Excuse me. So why is MOVIN a little different? It was great because we were involved in this conversation with other organizations across the country. We thought about, can we use MOVIN as a case study? And what we actually came up with, one of the things we struggle with is that MOVIN has built-in implementation strategies already in the design. So if you look at implementation approaches, they often focus on creating a hospital soil, modifying the context to fit and accept the intervention after the intervention is designed. We did this completely opposite. We designed MOVIN using a human factors approach, which is based on designing the intervention to fit the user in the context from the beginning. So we were creating, not realizing we were creating better seeds to improve the intervention to fit the context. And so implementation strategies were naturally just built into our design. So here's some of the strategies that are naturally built in. So we thought about, how do we train and educate the stakeholders? How do we develop these stakeholder interrelationships? And we were adapting and building that in. How do we adapt and tailor MOVIN, adhering to 5 critical components, but made sense within the context of this unit, this organization? So staff volunteer to participate in our training. We don't tell them they have to. All of our materials were developed in context with nurses and physical therapy. We built a strong coalition between nursing and physical therapy, and we used whatever mobility protocol they had. We didn't introduce anything new. We were like, what are you using? Great, we're gonna build this in here. This is an easy place for us to build it into our training. We thought about resources, and so we thought about financial strategies for that. So looking at, can the hospital do an allocation to hire a mobility aid? And for this intervention, we actually gave funds to hire the mobility aid on the unit. We thought about communications. We used iterative and evaluation strategies for that. The whiteboard in each room, which we built into MOVIN, we thought about, they designed their template that made sense for them and it fit their unit, as long as it hit our critical core components. The communication flyers are always updated staff on their ambulation activities. So it's really provided a lot of support for their clinicians on the unit. The environment, one of the built-in implementation strategies changed the infrastructure. All we did was install distance markers in the floor. We didn't do any huge changes in the structure. It was a pretty simple change that was quite effective at thinking about distances that patients were walking in. Now we had a mechanism to communicate to the staff the improvements they were making. Again, support to clinicians, adapting and tailoring. They picked out the distance markers. They picked out where they needed to be. They picked out the color, the design. It was like, we worked with them on what did they need, what made sense for their unit. Again, more financial strategies, small incentives to provide to staff for meeting these short-term goals, larger unit celebrations for when they hit their larger unit goals. It was a lot of fun. I think on this unit, one of the final goals is that they wanted to get to Lambeau. They were going to hit Lambeau Field. They had walked patients that kind of a distance from where we were to Lambeau Field in Green Bay. We had a whole Packer themed celebration going on. We had beads, we had green and gold, we had raffles. It was so much fun to engage them in that kind of a celebration. A lot of positive feedback and reminders. They're doing an amazing job for their patients, feeding them patient quotes on how this improved their outlook, their function, their perspective. Was really important as far as that we had already built into our intervention. So with that fast and furious presentation, I've got Lindsay on the line too that can help field some of these questions. I will tell you that it's been an amazing journey to have to link a nursing perspective with an engineering perspective to see what we can come up with that makes sense, and to think about measures in a little different way. How do we each bring strengths in our perspectives to improve patient ambulation during hospitals stays. With that, Heidi, we can take questions.
Thank you so much. That was a really exciting talk. And I want to encourage folks who are attending to either unmute yourself and ask a question or drop a question in the chat, and I can moderate that way. While we're waiting for folks to come in with questions, I'm going to drop the link for the evaluation survey into the chat. Please consider completing the evaluation because we do use your feedback to make subsequent DRISS seminars better. And Barb, my question for you is, did you collect any data about falls? Given that that seemed to be a big barrier, I'm wondering whether that panned out as something that
Heidi, I get asked that all the time. And actually, Mary Hook, our partner, is their informaticist at this one hospital. So she collects this data. She goes, oh, look at falls are down. Look at that, falls are down. In the RCT that we're running right now, we have a secondary analysis where we'll look at falls that happen pre-implementation and post. If you look at the mobility data on the other mobility programs that are out there, and Cynthia Brown has probably been the other big person that's been in this space. She also looked at falls, and she found that on her intervention unit, there were no falls. Where there were falls were the control unit, because people were losing their function. So I get asked this all the time. So I thought, all right, well, we can collect the data. I think one of the challenges with falls is because actually the frequency of falls are really not that high. So the sample size you have to actually say anything is massive. So it's challenging to say, how do we collect enough data to show there's actually a significant reduction in falls? So we're looking at it. We said we would look at it. I'm curious because, again, get asked this a lot. What happens to falls?
And I don't think your purpose is to show a reduction in falls as much as that you're, trying to show people that getting patients up and moving does not increase falls.
Well, the issue we have with this is the message interpretation when you bring falls into the picture. So when we bring falls into the picture, then it shifts how nursing staff start to think about falls. And so we do need to think about, I downplay falls a lot because I am so afraid of what that could do to shift behavior, that it's not something that I spend a ton of time on because of the work we've done on what happens to nurses with fall prevention programs. And I talk a lot about safe ambulation. This is about safe mobilities, getting patients up. And it's about maintaining or improving their functional status. And that's usually the message I hit pretty hard with.
So I actually have 4 questions, Barb. First, I'm going to say I always get so excited whenever I always hear more, learn more. Such great work. So this time, it always makes me think about something different. This time, it made me wonder that all the people that weren't trained, didn't get training, and then all of the, there's turnover, there's traveling nurse staff that come in and out. Mm-hmm. So do you have any understanding of, did the practice for nurses who weren't trained change? Did that stay the same? And how, in the long run, as there's nurse turnover on a unit, how can you sustain it? That's the first question.
All the questions, Jane, all great questions. So, when we first launched this, the very first time we launched this, they sustained for 3 years because it just became what they did on the unit. So we don't know how many of those nurses, how many of the 15 had stayed on that unit. We do know that they had experienced turnover because during our implementation, the very first time, we knew that there were people that went through the training that left and went to a different unit or a different hospital. So we knew that. We do know on, so the unit that we did the initial launch on this data, they did turn over their nurse manager after we were done, and they were just doing whatever they, in their own self-management of getting patients walking. So we know they turned over the nurse manager. We know they turned over their clinical nurse specialists. I know of 2 key launch RNs that turned over in that, and they still sustained. So if you think about, and that's really important for us to think about, what is the robustness of these types of interventions when you can change culture that happens on units? Does that behavior sustain because you've had some opportunity to shift how they perceive the importance of ambulation as part of the work they do? We've had in our RCT, we've had experienced a lot of turnover, and we've been able to see sustainment even with that. So one of our units, we launched this in the beginning of the pandemic. I thought we have got to be out of our minds. So we are going to go and see what happens. And statistically significant improvements in frequency and distance that patients were walking. We've actually looked at some of their data related to barriers for patient ambulation and how they perceive ambulation culture. And Lindsay has done most of the work looking at those results. Roger, this is not a patient data, so I'm going to share this. So what we found is we saw a significant improvement in a decrease in what they perceived to be barriers, and improvement in how they perceived ambulation culture. We didn't match those surveys, which is a limitation. So they were, we don't know if the individuals took it post. We're all same group that took it pre, so that's one of our challenges. But even if they were brand new and coming in, the question is there something going on within the unit level that there was perceived to be less barriers or an improvement in ambulation culture? So that's important. It's important for us to think about what that turnover looks like, and then how do we think about continuing? I mean, does that infuse throughout the unit? It's expensive to train people, especially if you're paying for PT time. Yeah. So the Wisconsin Hospital Association has jumped on board with this intervention. And one of our dissemination plan was to, their quality improvement group was to work with them to see if they had any hospitals that wanted to try a launch. So we have a hospital in Toma and a hospital in Hayward. They just have our manual. And they're like, we're touching base with them. Like, how are things going? Like, how are you able to do this? So, so we'll be able to see, when you don't have Lindsay and I involved as the, the major, one of the maybe potentially influencing factor, does it still do the same impact of what we saw? And maybe they can track this turnover a little better than what we've been able to see from larger organizations. So, and then what actually happens? Good questions, Jane.
You know, we're running out of time here, but one thing that this conversation is making me think about, Barb, is in your manual, do you incorporate suggested evaluation metrics so that implementing systems
Yep.
can evaluate themselves?
Yep. So we have, here's the templates, here's your evaluation metrics, here's how you capture this from your EHR, here's how you give feedback. So those are all appendices within the manual itself. So it really sets the organization up. They don't have to create. They think about, well, okay, we can adapt this to our organization, and here's how we can adapt it. And again, a lot of this came from the E2I funding that we got. Thank you very much. So, which really helped us think about how do you put together a really nice polished product that you can get out there.
Well, thank you so much for sharing your work with us. It's really exciting and interesting, and I can't wait to hear more about the R01.
Yep. Lindsay, do you have anything you want to add? Lindsay or Roger, because I know you guys are on board.
No, I was just going to say thanks for the good questions, and thanks everyone for coming.
My next question, my subsequent question, even though we're out of time almost, is given that the training seems to be one of the heaviest lifts of implementation, are you considering streamlined versions and evaluating their kind of figuring out the key components and how to streamline?
Yeah, you know, one of the ideas we had for a larger D&I grant, and Lindsay would have to jump in on, is an analysis that maybe helps us think about, can we sift out which of these 5 seem to be playing a larger role? We don't know. What nurses tell us is everything's important. So what can be tweaked and streamlined, what, you know, it's going to be really interesting to see what Hayward and Homa is doing, because they know that these are 5 components. They're going to adapt, and already they're adapting the psychomotor skills because they're so small they can't pull all their staff. So they're thinking about how to chunk and deliver information using virtual mechanisms so that they spend less time off units and can do this by other means. So be interesting to see what they do.
Excellent. Well, thank you so much. Please take a moment, click on the link in the chat to complete your evaluation of the DRISS seminar. Thank you, Barb and Lindsay, for your work. And we're looking forward to hearing more. Maybe you can come back next year and share some updates. Have a great weekend, everyone. Thank you very much.
Thanks for the invite.